Welcome to today's webinar with One for the World. Good evening to those of you in the UK and good afternoon to those of you in the US. I'm delighted to be joined by Dr. Gabby Laing and Dr. Wendy Harrison from the Schistosomiasis Control Initiative, and I'll tell you a little bit more about them in a second before they tell you a lot more about them. My name's Jack Lewis. I'm the Executive Director of One for the World. And I'd like to start off just by telling you what One for the World is. So we are a group of people who pledge 1% of our income to what we believe are the most cost-effective charities in the world. And I'm pleased to say that the SCI Foundation has been in that group for a long time because of their fantastic work, which you're all here to hear about today. Why is it important to pledge 1% of your income to any charity? Well, because at the moment there are about 590 million people living in poverty, and the World Bank said this week that this will be the first year since 1998 when more people slide back into extreme poverty than come out of it. So this is already an enormous problem where in truth we probably underestimate the scale of it when we're going about our daily lives, but unfortunately current circumstances mean for the first time in 2 decades it's about to get even worse. And the net result of all these people living on less than $1.90 a day is that around 11,000 children every day under the age of 5 die from totally preventable poverty-related causes. So while you and I will never lose a child to diarrhea or malnutrition or have members of our family die from malaria, unfortunately, that is an everyday reality for people across the developing world. And it's not just the things that I've just named there, which might be the first things that come to mind. It's also things like intestinal worms, which is what SCI do such a brilliant job of helping to prevent. And because we've worked with GiveWell, who are the world's leading charity evaluator, we've managed to identify charities like SCI who can prevent these terrible deaths and terribly debilitating conditions for tiny, tiny amounts of money. So you might be thinking, well, Jack, what is 1% of my income going to do? I'm not a billionaire. Well, for the cost of only a few dollars, you can provide an effective intestinal worm treatment to a child. You can provide a chemo prevention program that will stop a child from contracting malaria. You can provide a long-lasting insecticide-treated bed net that will prevent a pregnant woman or a child from contracting malaria. So One for the World is an easy way to do this. If you want to go on our website, we'd love you to consider taking the pledge. And it's an opportunity to have an enormous impact at no noticeable cost to yourselves. Now, every time I tell people about this, one of the first questions they ask is, well, you know, how do these charities work that they can do such an amazing job for such a small amount of money? And that's why I'm delighted to welcome today our 2 guests from the SCI Foundation. SCI does incredible work for almost no money. It's been one of the GiveWell recommended charities and recommended by other charity evaluators for years now, and it's been one of the charities that One for the World has recommended from its very foundation. So I'm really delighted to see Dr. Gabby Laing and Dr. Wendy Harrison here. I'm going to let them briefly introduce themselves, but thank you very much for joining us, and guys, over to you.
Brilliant. Well, thank you so much, Jack, and for that great introduction, and also just to congratulate and thank you for all the great work that you do for One for the World. And we're so enormously grateful for you guys getting the word out, and we really appreciate all your support. So my name's Wendy Harrison. I am the CEO at the SCI, and sort of very briefly, I've had quite a checkered past. I actually trained as a vet, and I've worked in academia, the pharmaceutical industry, and also now obviously in the charity sector, and hopefully bring skills from all those different areas to this job now. Firstly, also just to thank everyone for giving up their evenings or afternoons to be with us. And really what Gabby and I would like to do with our time together this afternoon is really firstly just to give a very short overview of the SCI, and knowing that all of you will be very familiar with GiveWell, so we won't won't focus too much on that, but there's just a couple of points that I'd like to bring out. And also then to talk about the importance of taking this One Health approach to our work, where we consider both the animal and human health systems together, which sadly at the moment, when obviously we look at the current pandemic that was of course originated in the animal population, and also in fact all the recent epidemics that we have had. So we also really want to make sure that we answer the questions that you're interested in hearing about. So we'll really try and keep our presentation just to 25 minutes. But also just to warn you that we do have a little quiz for you, just to make sure that we even up the questioning. So if I could just ask perhaps Gabby to share your screen, and we can just quickly go through the slides. Thank you. So while Gabby's just doing that, so as some of you may know, the SCI was founded in 2002 by with one of the very first Bill and Melinda Gates Foundation grants. And actually, I think there was only about 8 people in the whole of the Gates Foundation at that stage. And the award was about $30 million actually, and it was awarded to Imperial College. And we've actually been incubated there, and really until last year, when excitingly we actually moved out of Imperial to set ourselves up as our own independent agency. We also went through a little bit of rebranding, but not too much, just so that people would still recognize us. And so we're now the SCI Foundation. And our real vision there, which is very similar to really how it's always been since our foundation, but really is a world free of preventable disease, so that everyone everywhere can fulfill their potential. And so you may know that the preventable diseases that we really focus on are these parasitic worm infections. They obviously include schistosomiasis and intestinal worm infections, as Jack said. And these parasites belong to a broader group called the neglected zoonotic disease, the neglected tropical diseases. And about half this group, so there's about 20 diseases that the WHO recognized to be part of this group. And about half of those have an animal in their life cycle, so essentially are a zoonotic disease. Now, biologically, these diseases have very little in common, but what they do have in common is actually the populations that they affect. And they affect really marginalized, often rural populations with very poor access to health services and without access to clean water and sanitation. And the WHO estimate that these diseases infect over 1 billion people. And the highest levels of infection are mostly found in children. And these infections not only cause an impact on development of children, impairing their abilities for cognitive development, but also reduce productivity in later life. They can also increase the risk of other infections. And actually a quite recent study carried out by Jennifer Downs and her colleagues in Tanzania found that there was a 3 to 4 times increased risk of HIV in women that were infected with schistosomiasis. They also reduce school attendance, cause significant organ damage, particularly the liver, the urinary tract, and the gastrointestinal tract, and can cause severe infertility. But we do have a very safe and effective treatment. So we have albendazole that treats the intestinal worms, and praziquantel that treats schistosomiasis, amongst other parasites, which we'll hear a little bit more about later on. And the safety profile of these drugs is such that we don't actually have to diagnose each person and treat that person, we can actually just identify areas at very high risk, and we're then able to treat those whole populations, which is actually a much more cost-effective approach. And we found that by earlier and regular treatment, we can reduce the damaging effect of these infections, and we actually find that we can reduce by about 60% the rate of infection after just a single round of treatment. And a really groundbreaking study that was carried out by Edward Miguel and Michael Kramer, whose name you may recognize because actually last year he just got the Nobel Prize for development economics. And their study in Kenya showed that actually treating children with these drugs increased school attendance by 25%. But also in a follow-up study, really interestingly, found that actually treatment of in the school age years increased economic productivity by up to 40% in later life. So here we're not only tackling a very significant health burden, but we're also supporting the economic productivity of communities that obviously allows them themselves to work their way out of this vicious cycle of poverty. So we are very focused on the impact of these treatments in our everyday programming, and we do look at parasitological factors, so obviously the prevalence of the parasite in the population, and also the intensity of infection, because obviously, as you can imagine, the larger number of the worms that children harbour, the more severe their symptoms are going to be. But as many of you may know, what's really interesting is looking at a metric of impact that can be compared across different interventions and different diseases, and this is obviously really important, you know, when we're trying to allocate resources in the most effective way. And so we use the disability adjusted life year, and I'm sure that many of you are familiar with this, but just for anyone who isn't, the disability adjusted life year is really just a way of trying to measure an overall disease burden that takes into account not only the ability of the disease to actually cause mortality, which in this metric they use years of life lost, but also takes into account the impact of living with a disability. And you can imagine with really chronic debilitating symptoms that this actually imposes a real burden not only on the person that is infected, but also on their immediate family, because they need care, and also their ability to be able to contribute both socially and financially to their family and their community. And in some work that we've done, we've showed that we have contributed nearly 750,000 DALYs averted since 2010. So obviously, having that real focus on impact, we also want to look at cost effectiveness, and ourselves and many other deworming charities have come up with a figure that we can, for £1, we can treat 3 children. And in this kind of audience, just also to say that obviously to have this kind of impact, we need to be delivering at scale, and we have helped over 15 sub-Saharan African countries, and we aim to treat all individuals at risk of infection, and since 2002 we have delivered over 200 million treatments. Now we're very passionate about working directly with the Ministries of Health, and we think this really is a really sustainable way of maintaining the gains and the impact of these treatments. And I'm very happy to talk a little bit more about that if anyone would like to ask a question around that. Obviously, it's not perfect. There's always pros and cons, but we really are quite passionate that this is the way forward. So would love to expand on that if anyone would like to hear more about that. And then, so just having looked at the impact, we now look at the cost effectiveness, and as I said, you know, we've got this statistic around that for £1 donated, we can treat up to 3 people, and obviously this is one of the evidence that we use for our GiveWell recommendation. But as I was saying, with this kind of audience, I know that you will, realise this is a very unnuanced figure, and always has the little asterisks at the side, because there really is a lot of caveats. And so what we try and do just on the next slide is to actually unpick this a little bit further, and actually look on a country by country approach, looking at the cost per delivery of treatment. And I apologise that this is a rather busy slide, but just what I wanted to just briefly touch on is that you can see on the bar chart on the right that there is a huge variation actually in the cost per treatment delivery in the different countries, and obviously you'll appreciate that this is because the cost of inputs in each country is very different. The geographical disbursement, the currency fluctuations, the economies of scale that can be achieved is different in different countries. But what we have done is working with Chris Fitzpatrick, who's an economist in the NTD department at WHO, is to really try to get some international benchmarks so that we can be really sure that even within that variation, we can have a standard of cost effectiveness. And we also do try and bring the impact and the costs together in the cost of averting one DALY. And so again, some of the work that we've been doing, and we're constantly trying to kind of evolve this methodology, is around £42 for every DALY that's averted. And obviously this then gives us some ability to compare that with other disease interventions. So having left Imperial, it gave us an opportunity to review our strategy, and also in the light of WHO resolution, and so this was in 2012. The WHO passed this resolution identifying elimination as the global target for schistosomiasis. And elimination, of course, is considered by some to really be the kind of holy grail, if you like, of cost effectiveness, because obviously the costs in the long run are reduced to kind of almost zero. And of course we're very proud of what we've achieved with our treatment program, but I think we're also aware that if we are going to reach this elimination target, that we do need to look at other interventions that prevent the onward transmission, as well as obviously using our treatment strategy. And so also, to eliminate these diseases, we need to reach everyone who's at risk, and this means reaching harder to reach populations, which is inevitably more expensive. And so we really need to think innovatively about how we can use the resources that we have, knowing that there's a lot of, and particularly at the moment, there's a lot of calls on philanthropic and bilateral funding. So really think about how we can utilize the resources we have, and how we can also work with other sectors that are working in the same communities as us, to really leverage all the available resources. And so what we have done is, in our new strategy, that we've then moved from having our treatment strategy as our main pillar to actually now having four pillars, a four-pillar approach. And again, I'm very happy to talk a little bit more about these if people are interested later on. But just really to focus on pillar 3 on the next slide, which is really around the environmental aspects. And this obviously focuses on how we can leverage resources from the veterinary public health sector, as well as water and sanitation. And really, knowing that many of the diseases that we're working on are zoonotic, including one of the species of schistosomiasis, and that also the resources of the veterinary public health sector are often targeting very similar populations, and actually obviously carrying out quite similar activities, although obviously focused on slightly different species. So with that, I'm now just going to hand over to Gabby, who's recently joined the SCI Foundation as our One Health policy advisor, just to talk a little bit more about the One Health approach. Thank you.
Hi, so it's good to be here. Thank you very much for having me. And I'm another vet. I went back to do a PhD, so branched out a little bit, and I was working out in Ethiopia and with working horses. And it was apparent when you were there just how closely people were interacting with their animals, how much their livelihoods depended on that. And how close that relationship was in terms of you know, being able to afford food, schooling, medical care. So when I came back to the UK, I wanted to understand how policy is used to help with that kind of relationship, and that's really when I got into One Health. And so it's great now to move into the human health sector, the public health, and it's great to see so many vets tuned in as well, who are also engaging across from veterinary public health into human public health. So we just wanted to keep you on your toes a little bit and give you a little bit of a quiz to start with to illustrate a couple of our points. So the first question is, in those pastoralist communities worldwide, how many people do we think are working and living with animals and reliant on them for their livelihoods? Are we talking about 50 million people with 100 million animals, 100 million people with 500 million animals, or 300 million people with 1 billion animals? And I'm sure you're all really enjoying all of the Zoom quizzes you're doing at home at the moment, so I'll just give you a second. Well, unsurprisingly, it's 300 million people with 1 billion animals. So this is a huge, huge number of people that we have the ability to cross over animal, human health sectors and really, really help with livelihoods and those zoonotic diseases. And we all know that animals and humans can be very different, but they can also be very similar. So there was a report of one of these animals being confused at a crime scene. Does anybody know which one that might be? And it's the koala. Perhaps you thought the gorilla, but the koala have got so similar fingerprints that they sometimes get mixed up. So slightly fun questions, but slightly more serious questions. We're talking about endemic diseases. We're talking about diseases that exist and transmit around the population already. These diseases can pass between humans and animals, and they're called zoonotic diseases. So that might be through a vector, which might be an animal, an insect, or a livestock animal like cattle. What percentage of those diseases do we think are zoonotic out of all the infectious diseases? Are we looking at 60%, 10%, or 30%? And up to 60% of all the diseases that we're already trying to treat and control are zoonotic. So they have an animal health element, and veterinary public health therefore has a potential input into the control of those diseases. And then when we make the distinction between those existing diseases and we say that they're endemic diseases, we look at those emerging diseases. So just like COVID, like Ebola, like SARS before it, these are diseases where they jump species, so they're emerging, they're new infections. And what percentage of those new infections do we think have got an animal origin? And that's 75%. So you can see there's a huge number of these infections that are coming from an animal base. So it's really important when we're talking about preventing the next pandemics or dealing with pandemics and new infectious diseases that we do incorporate veterinary public health. But let's have a little look at the money spent. So in the US, the monetary value of overseas financial aid for malaria is the same as the US spends on pet Halloween costumes. Is it the same as London spends on takeaway coffee, or is it the same as we spend on dog food? And slightly disappointingly, it is as much money as we're spending on pet Halloween costumes, which is spent on overseas aid for malaria. So there's a huge potential for us to make an impact, maybe increase that funding, and it's really great to see so many people engaged in effective altruism and pledging a percentage of their income through One for the World. So what is One Health? So following on from Wendy's point that really when we're looking at eradicating diseases, we need to think about prevention rather than cure. We want to achieve eradication, and this requires us to really look at the wider context of the disease and its transmission, the system that surrounds it really. So One Health really is the acknowledgement that people and animals live and exist in a shared environment, and there's interactions between those, and that we need this integrated whole society, whole systems approach to really improve health. So if we're looking at schistosomiasis, for example, in the interventions that we use are effective against the, and also effective against another parasite. So we're getting kind of a double whammy. So when we look at just disease on its own, we look at schistosomiasis, we use a praziquantel drug with the school-age children, but we're actually also getting impact in cysticercosis as well, which is a tapeworm which can get into people's brains, called brain lesions, and then in areas where this is present, it's the main cause of epilepsy. So some really good opportunities there to try to get working towards eradication, and B, being able to tackle other diseases without necessarily changing too much about what we're doing, just getting efficiencies after that. So if we just want to touch on cysticercosis, so in schistosomiasis is the original disease that the SCI has been focusing on, and that's a disease that passes between snails as their intermediary host and then back to people. But in cysticercosis, it's a relationship between a man and his pig, which is the cause for transmission. So people are unfortunately infected through eating pork, which has got the tapeworm eggs in the meat. So if we look at that in a little bit more detail, then what we're looking at is the people becoming infected. The tapeworms generally live in the intestine and cause intestinal inflammation. They are passed out in the feces, and then pigs are exposed to sewerage, or the land is contaminated, used as a manure, for example, or water sources contaminated with sewage through poor sanitation and hygiene, and that means then that pigs be exposed to the eggs that are passed out, and then the pigs become infected, and the pork then is affected. But also, one of the problems is that the tapeworm can burrow out of the intestine. It's a bit gross, sorry, but can burrow out of the intestine and make its way to the brain, and it can cause brain lesions in people, and that can go on to then cause epilepsy, which is obviously a very serious disease that we'd want to avoid. But the good news is that the praziquantel, which is the drug that's administered to control schistosomiasis, also is effective against the adult cysticercosis, the tapeworms that are living in the adults. So it makes sense for us to collaborate with other groups that are working on this disease, as well as schistosomiasis, and with the veterinary public health. So as an example, if we're going to think about how we might use a whole systems approach to schistosomiasis, the single sector approach would be mass drug administration. So to tackle schistosomiasis, we're using a drug mostly in school-age children, which kills the adult worms. And we can do this at large scale because it's a cheap and it's very safe drug to use. So despite how many worms you might have, it's very safe to use. And it's also very much cheaper than perhaps diagnosing each individual case and treating them at the moment. So the logistics and the costs of being able to treat and to test and then treat are just too much at the moment. Praziquantel is very effective at killing the adult worms, but it doesn't prevent infection in the first place. So you don't avoid the damage to internal organs and those kinds of things that can come along with infection. And it doesn't protect them for any longer than the immediate dose. So the dose will kill the adult worms, but there's also the potential for them to become immediately reinfected. Also, when we look at continued use, so in high-risk areas, for example, we might be going back on a yearly basis, and people might be receiving repeated drugs. We know from the animal health sector that using drugs and putting selection pressure onto the parasites by using the same drugs repeatedly, we can run the risk of antimicrobial resistance developing, and that's something that Rob Mathers touched on last week with the malaria. And there are increased costs with both dealing with it once it's emerged, but ideally we want those kind of costs to be spent now before it really emerges, because there is evidence that once it has emerged, it becomes a part of that pathogen's kind of skill set. Even if you take away the selection pressure that led to its emergence, they don't return back to how they were before. So there is some memory for that resistance. So really what we want to do is avoid it happening in the first place. So obviously mass drug administration has its role. It's hugely impactful and incredibly beneficial for a lot of people, but it's also limited in its ability to really eradicate the disease. By eradication, we mean eradication as a public health problem, which means less than 1% prevalence in countries. So what we'd really like to do is embrace the multi-sector approach. And we want to aim for kind of prevention and cure strategies. So we're still going to be using the mass drug administration. We still think there's an important place there for that to help. But we'd also like to try and think what the other areas we can target in the life cycle. And it makes sense to target the intermediary hosts, the zoonotic elements of these diseases. So in Schistosomiasis, snails, and in Cysticercosis, the pigs. And we can use things like chemical molluscicides to kill the snails off, but we also have to think about how that might impact damaging the environment, or how it might impact on the non-target species, or on those species perhaps that feed on the snails, for example, and whether we might be at risk of contaminating things like local water sources and things. But where there are some more complicated things to think about as to whether we choose these strategies. For things, example for pigs, there are some really effective strategies that we can employ without those kind of complicated things. And one of those that's been demonstrated is just simply fencing the pigs off. So having areas that are designated for livestock and just stopping them coming into contact with the eggs in the first place has been very effective. And then to try to avoid the risk of antimicrobial resistance emerging, we'd really only like to treat those people in high-risk areas. But this is what SCI are already doing, but these kinds of campaigns rely on good surveillance systems, and if we can collaborate across human and veterinary and environmental health surveillance as well, then we get increased efficiencies and we can improve the accuracy of those risk assessments so that we can then make better targeted treatment choices. It's also helpful to work with social scientists, so understanding cultural practices that might put people at risk. So for example, a classic one is wash stations, so just sinks and soap being installed in villages outside people's homes, but they're not being used because people still go to the lake to do their laundry or their pot washing and things, and that's because there was a social aspect of going to the lake. So understanding how people what motivates people's behaviour, and also how they're interacting with livestock or wildlife, for example, shared water sources and grazing and crops, things like that. They're not always a simple solution, but sometimes there are, and otherwise we can work towards trying to find a way that's non-disruptive for people, but also has the desired outcome. We want to also help to reduce our impact on the community in other ways. For example, if we're going out and doing community engagement and education campaigns, and other charities are with the same messages, whether that be from veterinary public health or from human public health, for other diseases, for example, then can we consolidate that, make those a shared campaign? There's even an example of vaccination campaigns whereby the main vaccination campaign was cattle, or there was one for childhood vaccines, but there was better uptake for people attending for the livestock vaccines. So could we, they've been looking at running them in tandem so that that people can use their time efficiently as well, and these livestock are an incredibly integral part of their livelihood. So it's a good motivator for people to attend to receive any benefits. And I think the benefits of this whole systems approach, and including the wider infrastructure where SCI supports the existing health ministries and health systems for surveillance and things, and that's really being felt now in the face of COVID-19, where these health systems are just being repurposed and reapplied to deal with the new diseases that are coming out. But these are the departments that have been supported and trained to deal with the existing neglected diseases, but now that has huge benefits as well. And just to say that the One Health concept has been supported both by the World Bank and from the Tripartite, which is the UN organisations, the Food and Agricultural Organization, the World Organization for Animal Health, and the World Health Organization. And it's really great to see all of these people coming together, whether it's in the case of COVID-19 or the ongoing neglected tropical diseases which are endemic. Everybody coming together and try to identify ways which can work together. So I think that should cover us for now, and I'm happy to take questions.
Great, thank you guys. Those were truly, this webinar series has been very good, and those were two of the most interesting presentations that we've had so far. So thank you very much. We really appreciate it. I'd like to kick us off by asking if you know of any koalas that have been convicted of crimes that you think were actually committed by humans or vice versa, which you can research as we go on. For everybody who's watching, please make use of the question and answer function. It's at the bottom of the Zoom window, and we will try to answer as many of your questions as we can. I'm going to start off with a question from Bara, who says, they wonder how you compete or cooperate with other organisations that provide treatment for intestinal worms. And is there any difference in your level of collaboration depending on whether those organisations are non-profit or private sector?
Great. Thank you. If I jump in for initially on that one, yeah, that's an absolutely great question, and I would focus that we're very much on the cooperate rather than the compete end of the spectrum. And yeah, I mean, clearly this is incredibly important, and I think underlines one of the reasons that we work so closely with the Ministries of Health, because obviously these are Ministry of Health programs. These are national health programs, and we very much want to ensure that we're supporting the national health needs in these countries, and not kind of in a parallel and often very unhelpful way. Setting up standalone programs. So the excellent one, and really the absolute key is that cooperation and partnership with countries, but also recognising that there are a large number of organisations that support these activities, which is excellent. And I think one thing to say is that in terms of the profit versus not for profit, again, as many of you may know, that actually albendazole and mebendazole, which are the two most common drugs used for intestinal worms, are actually both donated by the pharmaceutical company GlaxoSmithKline for albendazole and Johnson & Johnson for mebendazole. And the WHO also coordinates the distribution or assists with the distribution of those donated drugs. So really there's several levels of kind of cooperation. There's obviously the allocation of drugs to through the WHO pharma kind of links, and then there's also the ability of the national health systems themselves to obviously identify where their gaps are and work with appropriate partners. But yes, I mean, we really never want to kind of duplicate. We know that the resources that we have available are so minimal that we never want to kind of duplicate another organization's work, and so we are also part of a large number of networks that the sort of NTD community also has within it, sort of disease-specific groupings as well. So there is a really large degree of cooperation across the whole area. I think that's a great question. Thank you.
Great, and it's really heartening to hear about how you collaborate with local health ministries, because something that gets the effective giving community gets challenged with sometimes is that we tend to fund things that have very high cost effectiveness, which don't necessarily result in systemic change. But actually lots of our charities have been telling us about how they're able to bring about systemic change by being very, very effective at treating, one condition, or in your case, a sort of range of neglected diseases.
Absolutely. And I think that is a discussion that we've been having with GiveWell and other organisations, because my always premise is just over what time period are you measuring the cost effectiveness? Because obviously if you're measuring on an annual basis, then absolutely, you can understand how things like very quick parallel systems are more appropriate because you can show results much more quickly. But actually, if you're looking at cost effectiveness over a longer period, then actually you can get very significant cost reductions, having invested in capacity development within the ministries, and training and cascade training down into the kind of the more local and divisional health systems. So I think it's really key that we pinpoint over what time we're measuring that cost effectiveness, and and we are very passionate, and I think it's it's in sort of in currently the horrible situation that we find ourselves, though, that really we want to use our single group of diseases and interventions, but really our ultimate goal is to strengthen the health system itself so that they are resilient and able to deal with a whole range of different diseases. And as we see now, with the COVID crisis, we actually do feel that we have equipped some of those ministries with the ability to respond to the situation. So it really is at the heart of what we do.
And I want to come in and echo this quite passionately, because GiveWell and One for the World and other organisations who are in this sort of meta charity space where we ask people to donate to organisations other than ourselves are getting asked a lot about coronavirus and what people should do. The answer, certainly as far as we're concerned and GiveWell are concerned, is keep donating to the charities that we already recommend. They're incredibly effective. They've been proven to be effective over extended periods of time with extremely rigorous testing. And none of the problems that they address are going to get any better when coronavirus is rampant in these countries. These problems are not going away. And not only that, but organizations like the SCI Foundation are perfectly placed to try and build resilience in advance and help with the response because of their local connections.
Absolutely.
On that theme, I have a couple of questions have come in around COVID response. So Meg has said, you've mentioned that you think that the current circumstances will push forward the One Health approach.
Yeah.
But when you're thinking about how this will be operationalized in the future, is it difficult when you require a change in mindset and a different approach to health at a sort of strategic level? And what lessons can you share from that with other organizations?
Thank you, Meg. That's the awesome question. And I think the concept of these different sectors working together is not difficult to get your head around. But I think, as in so many situations, the actually operationalizing of it absolutely is. And I think that what we actually have done is to take some lessons from other sectors. And the water and sanitation sector actually have been very proactive and successful in forging links with the health sector, and particularly from our side, the NTDs and water and sanitation have developed a very effective WHO strategy, and underneath that they have an operational guide, so a kind of toolkit, if you like, of actually some of the very basic things you need to do and recognize to bring two sectors together, almost kind of translating one sector's kind of language, but also understanding, what are their drivers, what are the key success factors for that sector, and how can you bring the same success factors from both sides together. And we're also very fortunate that actually this year the WHO is launching their NTD roadmap. So this really sets out how we're going to get to, for schistosomiasis, how we're going to get to that elimination target. And within that roadmap, it very clearly indicates the pillars that need to be in place. And obviously veterinary public health as well as vector control and behavior change are all within that document. So I think that having that leadership at the WHO level is really helpful. And then I think that Meg is absolutely right. The operationalization of that is actually really challenging, and we are looking to other sectors that have done it well, but I think he's going to take a significant amount of momentum and will from a number of sectors, and we, I guess, at the SCI really wanting to kind of spearhead that approach.
And as a follow-up to that, this is coming from an anonymous attendee, and they say, I'm sure you will have encountered some obstacles during your community education efforts. With the current pandemic, we're seeing a worrying rise in conspiracy theories. Do you have any tips on how you combat misinformation in your experience?
Wow, that's another really great question. And I think because of the way that we have worked with ministries for an extended period of time, I think we have built up a very high level of trust with the ministries, and we very much pride ourselves on obviously having started in in an academic institution, and in fact the same academic institution that now is advising the government on COVID, we have really ensured that everything we have done has been absolutely evidence-based, and so I think really that level of trust between ourselves and the ministry has been incredibly useful, and so we are able to kind of leverage that to kind of ensure that the appropriate messaging. But yeah, I mean, I think it's just so challenging at the moment, because I think these conspiracy theories are coming from all levels, not only, you know, very local, but also all the way up through to international organizations and heads of state. So I think it's an enormously challenging situation.
And I think if I could just come in there, just to say that One Health isn't just about vets and medics working together in human and veterinary public health. It's about the social sciences, environmental health people, you know, politicians coming in, and everybody being able to kind of recognise the benefit that each brings, and how those relationships can be complementary and symbiotic, in the sense that when you bring people together and they work together, that's going to produce more than the sum of their parts. So valuing social science, and certainly I know friends working in Public Health England now on the social side of the COVID outbreak, you know, what's driving people's behaviours, trying to get to the bottom of that, and then it's not just being a didactic system whereby public health authorities are putting a message out and expecting people to listen. It's about understanding what's driving their behaviours and how can we change those things, you know, and help them to make the right decision and make it as an easy one.
Yeah, just on that note, do you guys work with any kind of, you know, behavioral scientists or people in similar fields? Because obviously one part of the treatment is supply, but the other chart is the demand and the appropriate use of what you're supplying. So how do you try to bridge that gap?
Yeah, that's again absolutely fantastic, and that and yes, we do. We have we comparatively recently have engaged an experienced social scientist to work on our team, and exactly to look at that demand side, and that has really been one of our pillars, our second pillar, around around the reduction in risk behaviours. And you know, as Gabby said, you know, it really is absolutely key to understand the motivation for these behaviours, and appreciate that in those circumstances, those behaviours, you know, fulfil a very important need, and we really need to make sure that we sort of fully understand that. And I think there is a growing community, I think, of social scientists, particularly working, you know, in the NTD sector, and you know, and again, we're kind of contributing to many of those fora, so absolutely key.
Mm. I have a question here where I understand so few of the words in it that I'm just going to read it to you. And it's worth saying that I did a degree in 2 dead languages, so I usually have an advanced start on this stuff. Is there any evidence of anthelmintic resistance developing with the use of praziquantel or albendazole in humans where those drugs are being regularly used?
Great question. Obviously both, and Gabby will also want to have a comment on this. You know, both of these drugs are and veterinary drugs. They were originally developed for animals, farmed animals, and resistance has developed to these drugs in veterinary practice. But currently, there has been no reported overt resistance to these drugs, and part of the reason of that is that we don't apply a high enough drug pressure consistently. Obviously, the compliance rate in farm animals is pretty high because they don't have much choice. Whereas, obviously, in the levels of coverage that we are achieving in people is, we think, not applying enough drug pressure currently. And there are also some sort of biological components of the parasite in people that may you know, reduce the likelihood of resistance, and also the life cycle is quite slow, which obviously reduces the likelihood of resistance. But one very interesting fact is that we are seeing some, again on the One Health side, we're seeing some hybridization of different types of Schistosomiasis species. So the schistosome is very species specific. So there is a bovine schistosome, there's a ovine schistosome, there's even a schistosome that has a predilection for hippopotamuses. So they're very sort of host specific, but there has been some evidence for the cattle schistosome and the human schistosome getting together, and there is a suspicion that hybrid may actually be slightly less responsive to praziquantel, but that is a kind of ongoing an ongoing situation. But it is something that both we are obviously concerned about, and also the WHO are really starting to think very carefully about how, as we increase our coverage and put more drug pressure on these parasites, to ensure that we don't create the situation where the drugs are no longer effective.
Just to say, really, a slightly different aspect of that is that antimicrobial resistance is one of the other really good opportunities for us to work out how we're going to collaborate, how we're going to have shared budgets, shared funding and grants, and work together at ministerial level across around the world, because it is like COVID it's a truly global problem, and it's only going to be tackled with some truly global thinking. So I think as a vehicle for One Health and a kind of a pressure to utilise it properly, I think antimicrobial resistance will be one of the big drivers for us really, for really those sectors to come together.
Which actually leads really well into another question that we've had from Bara again, which says, the evidence for your prevention and treatment of intestinal parasites and for the other neglected tropical diseases is really strong. But to what extent do you think that the international community's response to these issues is improving, and what can we do to nudge them to do more and better?
Yeah, I mean, wow, that's again a very good question. Yeah, I mean, I think that obviously originally they were called the neglected tropical diseases, because I think the international community was completely unaware of their existence, and often in many situations, because they affect very rural populations, that even sometimes the ministries within these countries themselves were unaware of the extent of the diseases. So, and I think we have moved on significantly from that point, but I think potentially because they're kind of chronic debilitating diseases rather than those that cause a very high mortality, sometimes it's kind of a bit more of a nuanced discussion around the burden and the impact. But I think there is a number of coalitions and groupings that are really trying to advocate for the inclusion of these diseases, in many kind of broader packages. We've got really good support from the British government and the UK government, the UK government and the US government around supporting the neglected tropical diseases, and a number of other governments, the German and Japanese government, again, are starting to support the initiative. And I think the challenge for us really is going to be, as we're sort of moving into the era of the SDGs, that actually the kind of single disease kind of approach is going to be something that the international community, I think, is going to look less favorably on appropriately. So I think what we're trying to do with this more kind of systems approach is really use our disease approach to support the broader strengthening of the system. So I think we've got to, we have to think really carefully about our advocacy messages, that we don't necessarily want to focus entirely on the disease. We want to really think about it as an opportunity to kind of work more broadly in a systems way. So I think that obviously a huge amount of advocacy is needed, and we're all as organizations and networks and coalitions trying to kind of move that forward. But I think the messaging is going to have to change, really to be aligned with those broader goals.
Absolutely. And just let me say, One for the World is primarily a movement of people. We're part of a wider group called Effective Altruism, trying to look at how you can do the most good. It is collective movements like this that are able to exert this kind of pressure. I know that some groups in EA are looking at the moment about whether the community should do more direct action, like signing petitions, like contacting people to try and persuade, elected representatives and so on. But one good way, if you're concerned about trying to change attitudes globally, is to become part of something like One for the World, where we are able collectively to advance these causes, raise awareness for them, and of course raise money for them. I just want to pick up, because you mentioned that the 2 drugs that you use were originally developed for use in animals. You're both vets. Perhaps you could talk about this as a route into the type of work you do, because it was surprising to me, certainly, and also in general about the kinds of people that you hire as a highly effective frontline charity.
Okay, so I guess if I just very quickly talk about kind of my route in here, into sort of where I am. As I said, I kind of had quite a checkered past, and I think that really my introduction was through another NGO while I was actually working at a university in the States that's called Heifer International. They also have an organization, a sister organization here called Send a Cow, and they basically donate livestock, and I see Jack nodding, to developing countries. And I worked in a voluntary capacity for them. And I think really, as Gabby was saying right at the beginning, you had a bit of a light bulb moment in terms of the kind of importance of the kind of animal-human interface in these countries. And I guess from where I was, the whole kind of international development sort of impact. And so I think that was kind of my moment, and I actually then went back to the London School of Hygiene and Tropical Medicine and did a human public health masters. But I think the joy I find of working in public health and in this kind of more sort of a cross-sector piece is that you're bringing together people with very different skill sets, perspectives, and strengths around a single problem. And I find that so rewarding. I mean, there are kind of sometimes sort of challenges, but I also just think it's so rewarding to have that breadth of experience, around a single problem. And so in terms of the people that we hire, we sort of deliberately don't have, a sort of very rigid idea, and I think we're very kind of open to looking at people with perhaps non-traditional, if you like, sort of backgrounds, but that have a real passion for the area and can bring in a slightly different skill set. So as you rightly pointed out, we've got social scientists, we've got vets, we've got nurses, we've got biostatisticians, we've got a whole kind of range of people with different kind of backgrounds. But really, all have that in common, that they're passionate about our goals, and prepared to put their kind of effort into solving that one particular problem.
Just say, just to say that as vets, we learn about One Health. Maybe it's not called One Health, although I think these days they are more and more using, an official module in One Health or of course in One Health. But we're vets on farms. Every animal, or farm animal especially, comes with an owner, and pets come with an owner. So you're practicing One Health right from day one when you're in veterinary school. So I think it naturally has drawn in more people from the veterinary sector, and maybe that's just because they haven't used the term in the human health sector as much yet, but it's certainly catching on. And I think whether you call it global health or One Medicine or One Health, I think these ideas are catching on and people are working together. I think public health and antimicrobial resistance are some of the really strong points. And then there's also the slightly more peripheral ones around, dogs being, beneficial in preventing signs of dementia from worsening, or in medical detection dogs, or, in different kinds of welfare, understanding of welfare or disease conditions and things like that. So there is a huge variety of things that can fall under the One Health banner. And I think when you're trained as a vet, it's kind of in tune. You can never learn everything about all of the species. So you tend to think about everything from first principles. And I think that really, that way of learning and thinking about problems really lends itself to One Health. And I'm hoping we can certainly work with the human public health sector and it kind of become more and more mainstream in the future.
Yeah.
Yeah.
And I always, oh, sorry, go on.
No, go on, Wendy.
No, I was just going to be very trite. When I teach medical students, I always start with my favorite joke is, what do you call a vet that only treats one species? A medic. You can imagine that goes down really well. Yeah.
Many people are celebrating frontline doctors and nurses, but not SCI, who are keen to have being so limited in their focus during these
an age-old rivalry.
Good. Yes, it's good to see someone pushing back on all this fawning. This is recorded, isn't it? Oh, damn.
Yeah,
so I'm sort of duty bound to say, I know we hire a lot of people straight out of university at One for the World. We have 5 amazing interns who are with us, paid interns, I should add, this summer. One of the best things you can do if you want to get a successful and impactful career is run a One for the World chapter. It will demonstrate that you have a set of skills and attitudes that is hugely valuable. So please bear that in mind. Guys, we've come up to 7 o'clock. I'm very conscious of respecting your time. That was so interesting. It was so interesting. We could easily go on. I'd like to leave the audience, first of all, by saying thank you so much, Dr. Wendy Harrison and Dr. Gabby Laing, for giving up your time this evening.
No problem.
And sorry, I left exactly the wrong pause there for you to jump in. But also to say to everyone who's watching, these organizations run by these amazing people need your help now more than ever. If you are in a position to donate just 1% of your income, please go to our website and consider doing that. And also, for those of you who are in the States, if you are about to receive a stimulus check under the CARES Act and you are fortunate enough not to need that, please consider #passing the check onto organizations like the Schistosomiasis Control Initiative Foundation. They will make fantastic use of it. Thank you very much for joining us. Thank you again to our guests.
Thank you.
And we'll see you all next week when we have Caroline Tetty, the Director of Recipient Advocacy from Give Directly, joining us.